Well, welcome back, and I hope you enjoyed that Talking Point segment. Now, most of you love this segment, and we are very fortunate to have the lovely Vanna Wounds, Sharon, back with us to spin. Hello, Sharon.
Hi, I'm delighted to be back again. Thanks to my stand-ins.
You've been off for a long time. Do you feel strong enough to do this? Have you been working out?
Oh, I haven't been off that long. So just occasionally here and there.
Well, globetrotting across the world, we're happy to have you back here to spin for us. Are you ready to go?
I'm ready to roll.
All right, give it a roll.
All right.
And around we go. We never know where the wheel of wound is going to stop, do we now?
Not really.
Well, you've been eating some Wheaties or something.
Well, you see, I've been gone for a while. I missed turning it, so.
Well, it's starting to slow down a little bit, and where are we going to stop? What wound are you going to be talking about today, Sharon? Pressure ulcer.
Oh, wow. One of my favorites to talk about, pressure ulcers.
You know, you're an expert in this area. Are you ready to share insight with our audience?
I absolutely am. I think we're going to focus maybe on wound assessment, which is such an important area, especially when we've been talking about all this documentation and computerization. So
very appropriate for the show.
Good.
Let's go right to Sharon, talking about pressure ulcers and documentation.
Hi, I'm Sharon Baranowski, and I'm pleased to be with you today as we talk about pressure ulcer assessment and the importance of documentation. As you are all quite aware, many reasons exist why a patient is at risk for pressure ulcer development. You can certainly see on this slide that just about every reason that a patient is admitted to our care gives us a reason why they can potentially be at risk for pressure ulcer development. We've all been told about the importance of taking risk assessments, and depending on the healthcare setting that you practice in, the Braden Risk Assessment Tool or the Norden Risk Assessment Tool or a form of a structured format for assessing a patient's risk for the development of pressure ulcers should be used. It is definitely recommended in long-term care that we have to have a pressure ulcer risk assessment tool in place. So when you're looking at risk assessment tools, again, I would tell you the most important part of a risk assessment tool is what you are scoring and looking at the numbers where you, in fact, may have scored someone with a 1 or a 2, and they are really at high risk if you do not look at developing an appropriate intervention to go along with that number that you scored. So the subscales are just as important as the total score. Now, when you're looking at assessment and staging of pressure ulcers, in order to have an accurate assessment, you must be able to accurately look and develop a plan of care that is going to help us achieve some good clinical outcomes in dealing with the pressure ulcers, no matter what their stage. We have to develop some consistency in our assessment so that when we're saying the patient has a stage 2 pressure ulcer, that we're all seeing the same thing. And that presents some challenges in clinical practice because pressure ulcer staging is so very subjective and very much based on the knowledge of the person doing the assessment. And then we have to look at, in all of the healthcare settings, what is our clinical path? How are we going to manage that patient? How are we looking at what we can do to prevent pressure ulcer development, to prevent further development or worsening of existing pressure ulcers, and we're using the appropriate products and supplies. I'm not going to be going through all of the definitions of the stages of pressure ulcers. I think you're all very familiar with those, and certainly you can find them in the National Pressure Ulcer Advisory Panel's clinical practice guidelines if you are not familiar with them. What I'm really going to focus on today is taking a look at a more in-depth basis of what we really need to assess when we're talking about pressure ulcers. First, in order to get that good assessment, we need to obviously be looking at the stage of the pressure ulcer. Then we have to be looking at where is it at. Those are the two things that are very important in our documentation, is what stage is the pressure ulcer and what is the location. We also should be measuring our pressure ulcers, looking at length, width, and depth. And again, these measurements can be somewhat subjective depending on how you achieve them. We need to also then take in the entire wound bed characteristics. And we're going to break that down further in just a few minutes. But looking at what you're seeing in that wound bed, the tissue type, the wound edges, the drainage, the exudate. Is there any pain? We're going to be talking about all of that and looking at concepts for infection. Now, there are 6 classifications for pressure ulcers, stage 1 through 4. Then the newest ones came out in about 2008, I believe it is, unstageable and deep tissue injury. So again, these are definitions that you can find on NPUIP's website. Again, getting back to that all-important location, what you see should be documented in anatomical terminology. We shouldn't be saying that it's just on the right hip, because we have various sizes of right hips. So we really need to be looking at where it's on the right trochanter. So using appropriate documentation. What you're seeing can also be combinations of things in various areas. You may have IAD along with pressure ulcers, or you may have both. So incontinence, associated dermatitis, as well as a pressure ulcer, one or other, or the both. Terminology, you need to be familiar with this terminology. So this should definitely all be part of a computerization system. If you're looking at getting involved in electronic management, these are terms that need to be able to be accessed as part of your documentation system and should be included when you're doing a good wound assessment. Again, we talked about the importance of measuring wounds. At least the recommendation for best practice is to measure once a week. And that is looking at the greatest length and the greatest width of the particular ulcer, keeping in mind that that is not necessarily the middle of the wound. Again, the greatest length and the greatest width, and then what is necessarily whatever you find in part of the wound has the deepest depth to it. Some of that depth is going to include tunneling or undermining. Well, undermining, you are going to be having under the edge of the wound an area where the top area of the skin is not connected to the tissue beneath, and that's considered undermining. And we should document those areas that you find and what location on the wound that they are. Are they at the 2 to 5 o'clock area, or at the 7 to 8 o'clock area? And then tunneling, obviously the same thing. You need to be measuring the depth of the tunneling. Exudate comes in many, many different forms. We have clear exudate, which is normally serous drainage. We have cloudy and milky exudate, which can also indicate the presence of inflammation, but it also can indicate the presence of infection. Then we have the basic pink and red exudate, where you've got some residual left over from the red blood cells, and then some capillary damage may be leaking out, where you've got some serosanguinous or sanguinous type of exudate. Green, not always a good color for exudate, because it certainly is indicative often of Pseudomonas infection. Yellow and brown, pretty normal, that you're going to see when you have bacteria in a wound that is sloughing, and it can also be from some type of a fistula type of drainage as well. Gray or blue may be related to the use of some of the dressings. A lot of the dressings that have silver products are sometimes oxidated by oxygen and can leave some residual gray and blue colors on wounds. Wound edges, very important. What are you seeing? Is there the undermining and the tunneling we discussed? Is it a rolled edge where you're never going to get the epithelialization across the wound bed? Is it flat where you can get good epithelialization occurring? So what do you see in the wound edges? As you see in these pictures, some with a great deal of undermining and some with a round, curved wound edge where you're not going to get epithelialization occurring. When you look at pressure ulcers, you're going to see many things. Pressure ulcers aren't always just all granular or all necrotic. Sometimes they're going to have, as you see in this photo, numerous things available to document. And these are all things that need to be documented. So we need to be looking at necrosis, granulation tissue, bone, slough, erythema, if there's any tunnels. So really, what do you see? And that's what gets documented. Infection, looking for the normal signs and symptoms of infection. Those really haven't changed. So be looking at for superficial infections. You can use the NERD and Stoney algorithm If you're interested in that, as I've shown you on the screen, or looking at what you normally consider the signs and symptoms of infection and being sure to report that to the appropriate physician. And pain often gets not documented often enough when we're dealing with pressure ulcers. Pressure ulcers are painful. The pain of dressing change is painful. So please be assessing your patient's pain scale, and please be sure to include that in your assessment. So I hope that this has kind of helped you so that when you're looking at patients, you are in fact looking at that whole patient, because that's really important, not just the hole in the patient. Thanks.